I'll now invite our pediatric panel to the stage. They are going to be, come right on up everybody. They're going to be sharing their experiences and perspectives on the same topics that we were discussing earlier today, but of course from the pediatric patient experience, both covering their experiences with the disease symptoms and health concerns, as well as their experiences with current treatments, current treatment approaches, how well those are working, and what they'd like to see from future therapy from their perspectives. So here today we have Rebecca, we have Logan and Logan's mom Erica, Gracie, and Addie. So I'll ask Rebecca to go ahead and take it away.
My name is Rebecca Taylor. I'm a 17-year-old high school junior from San Antonio, Texas. Learning is everything to me, and I pour all of my time, even my free time, into school. You learn to love it when you had it taken away from you, as I did when I was 7. I was diagnosed with chronic pancreatitis caused from an unknown immunologic disorder that is still being studied today. I have since spent over 1,300 nights in a hospital bed, have had over 85 anesthetic procedures, 22 of which were ERCPs. My search for a cure led me to 8 of the major hospitals across the United States, none of which provided an answer. When I was 12, I had to have the total pancreatectomy and auto islet cell transplant to save my life from the pancreatitis, but the transplant left behind many problems of its own. I have not experienced the pain of pancreatitis in over 5 years since my pancreas was removed, yet it still has a firm grasp on the way that I have to live life today. The pain of pancreatitis is unparalleled. None of my other 18+ afflictions even come close to the level on which pancreatitis tormented me. The pain was similar to a knife actively stabbing in my abdomen, but that's not where it ended. The extent of the pain reached to ripple across my entire body until I couldn't help but shake. Every square centimeter ached and nothing alleviated it, not even high-dosage narcotics. This kind of pain is debilitating and meant that I had to miss out on everyday activities such as school and seeing family members and friends. It kept me constrained to a bedside where my new life revolved around pain that is not only physical but mental. Each day I discover a new scar, a mental scar that pancreatitis has created and left behind. Certain moments of PTSD affect my everyday life, such as hearing certain words in a hospital setting that brings tears to my eyes, where I have to clutch my stomach in an attempt to protect it. The worst procedure I have ever endured once kept me up for 72 hours straight, screaming from the pain. I was 10 when I received this procedure, and it still wakes me up in the middle of the night from a deep sleep with phantom pain. Even my dreams to this day are still filled with pain. To have pain so bad that 5 years later the phantom pain impacts you should not be allowed and needs to be fixed. It's difficult to deal with both PTSD and medical depression as a high schooler, because as of yet, the emotional aspect of pancreatitis is not fully comprehended. The options for treatment for this are limited and scarce, and finding someone who knows how to help is nearly impossible. The transplant was not an option for me, but was necessary. It is not a cure. Instead, it is an exchange of one set of problems for the next. I now have a failed colon and massive amounts of scar tissue that are wrapped around my intestines. I have to take 3 to 9 cups of Miralax every single day just to keep me out of a hospital bed, and the pain attached to it leads to narcotic usage. Narcotic usage, which in turn leads to the slowing down of the intestines, which leads to an endless cycle of stop and go with the GI system. But the narcotics are the only option to alleviate even a fraction of the pain, and so they have to be used, and the cycle continues. Scar tissue provides issues of its own that creates incredibly severe pain that halts nearly every aspect of my life during its pain spells. Yet, it is very difficult to remove considering the lack of surgeons willing to attempt such a procedure on a unique anatomy that the transplant leaves behind. The transplant is a time buyer. Islet cells don't live forever. After my islet cells have all died at the 10 to 15 year mark, I will become a brittle diabetic and will have to carefully monitor sugar highs and lows. I will have to navigate life completely without the use of a pancreas, which is considered a vital organ. Even the missing spleen takes a toll and requires extra precautions to be taken by those around me, such as all of my friends and family members now have to get vaccinated early and have to avoid everyone around them who is sick. The school won't allow me to attend when a certain number of students are absent due to sickness, which means more missed school on my behalf, and even a slight temperature that I contract leads to yet another hospital stay, and the days of missed school piles up. This disease is not a disease that anyone should have to endure, but especially not children. No child needs to be in debilitating pain that is this bad, and they don't need to have their life taken away from them too soon. So for this, we need a cure so that we can have a better option than the transplant that is just an exchange of problems, so that we can finally have a cure that will treat pancreatitis as a whole instead of just trying to remove the pancreas.
Good morning. Logan is an amazing and resilient 7-year-old boy in the 2nd grade. Logan was first diagnosed with acute pancreatitis in March 2017 at the age of 4. At that time, it was also discovered that he had a choledochal cyst. This was surgically removed in April of 2017 and deemed the cause of his pancreatitis. We were told it was an event and it was over. Logan was again admitted in October of 2017. The attending stated this wasn't supposed to happen. They placed him on a low-fat diet and started him on Creon, digestive enzymes. At that time, the process of genetic testing began. He was again hospitalized in February of 2018, and at that time, it became known that he had a SPINK1 mutation. It was homozygotic on 2 variants. Once the genetic mutation was discovered, they stopped the Creon and stated low-fat diet would not make a difference. We had spent months learning and measuring fat grams, teaching him his new food rules, consoling him through the changes in adjustment, and supporting him in taking a medication with every meal. Then just like that, the rules changed. It was a whiplash for us, but even more so for him. He had learned eating a certain way kept him well. Now he learned that is not the case. It creates doubt in the mind of a child and impacts their buy-in into the next set of rules that we have to teach him. Logan is hospitalized 2 to 3 times a year with acute recurrent pancreatitis. There is no treatment for him, only management of symptoms. When this journey first started, hospital management included nothing by mouth for days. Then, all of a sudden, a few stays in, they decided food as soon as possible was better. Again, we taught him one thing and then changed it. It is confusing to a child, it is confusing to adults. This past summer, 2019, Logan was evaluated by the TPAIT team of University of Minnesota. We are instantly comfortable with their role as leading experts. We left informed and impressed. After completion of the evaluation, the team recommended him to have the total pancreatinectomy and islet auto transplant. Logan is treated at a children's hospital that vies for the #1 spot every year and never drops below the #2. We have access to the best, and what we are told is, your son has a progressive disease and there is no treatment. As we begin down the path of progression, the symptoms increase in severity and frequency. He identifies struggling most with the intensity of the pain, nausea, and fatigue. We will have to abruptly leave activities. We have carried him off the soccer field, and after a morning of activity, he has to rest and recover. When he is in a subacute flare, he is couch-bound and not able or willing to engage in activity. When it becomes an acute flare, he stops being able to walk upright. He will tell us every step is punches to my pancreas. He stops eating, stops drinking, and the pain creates a desperation for him. He is hunched when he walks, and it is a telltale sign that we are on our way to an admission. Providers explain that they can manage his pancreatitis, but there is no prevention or prediction. There are many theories as to what may precipitate an acute attack for him. However, he's had attacks with no precipitator identified. Logan wakes up, goes through his day, and goes to bed with the potential of the extraordinary pain coming at any moment. Since his last acute pancreatitis diagnosis, his recovery has been slow and stagnant. Prior, he would rebound. This time, he faces daily nausea, fatigue, pain, and difficulty after meals. As a family, we are constantly shuffling in our brains how to manage an inpatient stay when a flare of symptoms begins. He has a younger brother, now 4, who senses the preparation and needs consistent reassurance that he will not be left at school. Never have we done this, but this is the fear created in him. Our only option is a drastic and invasive operation. It is terrifying and comes with substantial risks. Unlike his first major surgery, where everything moved fast and we were not given a choice, we're left to determine the timing for this surgery. We are stuck in a game of guessing when he is sick enough, but not too sick. It is a terrifying place to be. We're beginning to see the compounding toll this is taking on Logan. It is affecting his soul and his light. He is beginning to have times of defeat, and the only option we have is to move our family out of state and for him to undergo an invasive, complicated surgery. So many aspects of the surgery terrify us. Sometimes it's details that really impact you. In order for Logan to have his islets transplanted, his pancreas will be brought to a lab. This lab is in a different city than the surgery will happen in. Our child will lay in the operating room while his pancreas is driven to another city, islets harvested, and then returned. There is no other option on the horizon. We are acutely aware that there are other families that would trade with us in a moment. We have an identified problem and an identified solution. We may not like the solution, but we understand how lucky we are to have one. We are also certain there are solutions, or at least treatments, already in existence. The cure could be sitting on a shelf, waiting to be labeled for this fight. Inflammation is a trigger for Logan's pancreatitis. Medications can target this, raise the threshold, or at least minimize it once it begins. This may limit damage if we can find those medications. If we limit damage, we limit progression. Slowing this down creates a wealth of time and opportunity to find the next step towards a cure much less invasive and risky than one that we are offered now. Great.
My name is Gracie Jamison. I'm 16 years old from Muskogee, Oklahoma. My sister Addie, my dad, and my grandmother all have hereditary pancreatitis. On my 16th birthday, I was practicing for my driver's test. I told my parents that my chest was hurting, but we thought it may be due to nerves about parallel parking. I started crying from the intense pain, which is not normal for me at all. So my parents took me to the emergency room, and because of the family history with hereditary pancreatitis, they requested the hospital run lipase and amylase counts. They started an IV with morphine and did blood work right away. My lipase was over 900, and I had to be admitted into the hospital 2 hours from home. I spent 3 days in the hospital. At first, I couldn't eat. Then I went on a clear diet to try to ease the pancreas back to functioning pain-free. Soon after the diagnosis of hereditary pancreatitis in April of 2019, I went to OU Children's in Oklahoma City to have an MRCP. They collaborated with my sister's team of doctors from Cincinnati Children's to make certain the scan was able to show the doctors the best results. Looking back, I'm certain I was having attacks earlier in life, but we attributed the pain to lactose intolerance or food allergies. Each time I feel pain, I get blood work done at the lab. Doctors want me to track my lipase and amylase counts. This has mandated many trips to the hospital lab, forcing us to leave whatever activity we're doing. Occasionally, ER doctors have made me feel stupid, telling me that I couldn't have pancreatitis because that's an alcoholic's disease, though I've never had a sip of alcohol or any other substance. It's even more discouraging when the counts would come back low, even though the pain had been high. I know the difference between a stomach ache and pancreas pain. Stomach pain is uncomfortable and eases within minutes. Pancreas pain is like a knife stabbing in my chest, and I can't breathe with the sharpness of it. It is intense and relentless. It makes it hard to ask for help when it is so severe. I've even spent time in the school office crying, seeking a quiet place so my peers didn't see me in pain. It's hard to tell others what is happening and what I need. When the pain is the most intense, it is debilitating to the point of crying. The severe pain generally lasts for 30 minutes or until the narcotics begin to take effect. In October of 2019, I had an ERCP done at Cincinnati Children's Hospital. A stent was placed into the duct to widen it since it was a little narrow. I had begun to notice a pattern with the pancreatitis attacks coming about 1 to 2 days before my menstrual cycle would start. I kept track on my phone calendar. When we were in Cincinnati for the ERCP, we mentioned the connection to Dr. Haja, who told us of a study she recently heard presented on this very condition. At this time, genetic testing was administered, and it was determined that I had the PRSS1 gene mutation. In December 2019, I had a full TPIAT evaluation. It was determined we would review and re-examine in 6 months. We opted to start birth control in an attempt to regulate periods and determine if pancreatitis attacks are directly related. Since starting birth controls, I've still had attacks with my periods. The main downside of this treatment is more frequent and heavier periods, and I feel more emotional, discouraged, and mad when experiencing pain. The pain requires me to leave school or work in order to take medications that allow it to subside. I try not to let the disease stop me from doing the things I enjoy, but sometimes it is inevitable. Besides hormones through the birth control, I do not take daily medications. I rely on ibuprofen for pain until it isn't effective. Then I take oxycodone. After taking this strong medicine, my day is spent in bed because it makes me exhausted. I stop eating for a while because of the pain that comes right after eating, to allow my pancreas time to rest. I increase fluids for nutrients and hydration. The doctors have described me as a science experiment. I am figuring out when I must take the narcotics versus ibuprofen, learning how to make myself comfortable when I hurt, what the protocol is at school in order to be excused from class, tracking periods and pancreas pain, learning how to determine whether I should drive myself or have someone come get me, learning when and what I should or should not eat. Even though I have watched my sister deal with this disease my whole life, I now have to learn the effects of this disease on my body and determine how I can best deal with the pain and life changes.
Good morning. I'm Addie Davison. You all just heard from my sister Gracie. I'm 15 years old from Northeast Oklahoma. At 4 years old, I complained to my pre-K teacher that my chest was hurting. She called my dad, who also has chronic hereditary pancreatitis. The way I hunched over from pain looked all too familiar to him. And then he took me to the doctor requesting they run a lipase and amylase count. My numbers were so high the test couldn't accurately count them. They confirmed I had pancreatitis. I was the youngest pancreatitis patient our doctor had ever seen. We then drove 2 hours to see a pediatric GI doctor. She sent us to the Mayo Clinic in Minnesota, where they did an ERCP at age 6. As I grew older, the attacks became more frequent and more painful. Being sick would mean missing out on dance, school, and church. The pain, hospital stays, and narcotics made school very challenging. Each attack brought with it nausea, excruciating pain, dehydration, and sometimes a hospital visit. I would lay on the floor and move all around, trying to get the pain to ease. The nausea was so bad that I couldn't function. I was given Finnergan pills and gels for it. The gels didn't do much, and the pills put me straight to sleep. But I would wake up just as sick. On top of that was the pain, the agonizing pain. I would first feel like I had pressure on my chest. I would stop eating, take an ibuprofen, and warm up a corn bag. My kindergarten teacher sewed a bag filled with dried corn or rice for me that could be placed in the microwave and heated. The heat and pressure of these bags was a comfort for me throughout the years of my illness. The pain would subside, then come back, but worse. It felt like I was being stabbed in the abdomen repeatedly. At that point, I would take a hydrocodone. The hydrocodone first made me feel groggy and absent. If I began throwing up, we would go to the hospital for IV fluids and morphine to offset the dehydration and try to get control of the pain. I remember begging nurses to start the IV one time so I could just get some relief. Over time, the symptoms became worse and the treatment became less effective. I built up a tolerance to hydrocodone and oxycodone, and the morphine would give me awful headaches. My liver began shutting down due to pancreatic stones and blockages in the duct, and because of strange insurance issues and God's plan, I was admitted to St. Francis Children's Hospital. There, they referred me to a GI specialist in Oklahoma City who had just learned of a surgery that corrected pancreatitis. The surgery involved the removal of the pancreas, spleen, gallbladder, and appendix. The insulin-producing islet cells would then be transplanted into the liver to control blood sugars. After a bit of a fight, my parents temporarily moved us to Cincinnati, where I had a total pancreatectomy with islet cell autotransplantation in December of 2017. I woke up from the surgery not only in pain, but scared. I was on about 25 IV drips, but there was still the pain and the nausea. For days, I laid in bed and sat in a chair, hardly moving because of the nausea. The trauma to my body or the drugs were causing violent nightmares, which lasted about 6 months after the surgery, and still happen sometimes. I took Seroquel, Neurontin, antibiotics, and Creon because my liver clotted after the transplant of the islet cells. I required a second surgery to break up the clotting, which resulted in heparin and Lovenox for weeks after the surgery. Because my blood sugars were so unstable, I went through hourly finger sticks for days. The biggest thing that I can remember is the nausea. I was vomiting frequently, which was not good given that my abdomen had just been sliced open. Nothing helped the nausea. Eventually, I was given medication for patients on chemo. It made me feel better, but only for a short time. Then it returned, but I couldn't have any more medicine. Days of nausea were finally cured by a tiny pink pill, Benadryl. At one point, I was taking around 30 pills per day, as well as managing an insulin pump and a Dexcom. But miraculously, within 12 weeks of the surgery, my islet cells began to fully function, and today I take no insulin to control blood sugars. I was on an antibiotic for the first year after surgery, as well as aspirin and blood thinners to help control my platelet counts. Since the surgery, I've been hospitalized 1 time for fever because I am asplenic. The TPIT was intense. The recovery was harder than anything I could have ever imagined. The second surgery was the worst case scenario. The nausea and night terrors were long-lasting and hard on my entire family. However, the absence of pancreatitis and chronic pain is worth it. After the surgery, I have grown 6 to 7 inches and gained around 40 pounds because I don't have a faulty pancreas draining every nutrient out of me. Hopefully, I can be a small part of the changes I wish to see in the development of a cure for pediatric pancreatitis.
Rebecca, Logan, Gracie, and Addie, thank you for your courage of sharing your stories today. Join me in thanking the whole panel again. So now we have the opportunity to broaden the discussion, as we did in the earlier session, to hear about the pediatric patient experience with pancreatitis. Like before, I'll be asking some questions and asking you to raise your hand to please share. We know that pancreatitis, as was mentioned, is quite a spectrum of a disease, and so even some of you that may have been sharing your experiences during the adult session, we know from the polling that 40% of you had your first symptoms in childhood. So we welcome you to also share your pediatric specific experiences as well. So I'll start us off with one question. We heard from a number of our panelists that they had different frequencies of kind of what I would call worst days, and that there might be certain things that they noticed preceding those worst days, something that might trigger those severe symptoms, perhaps even an acute attack. And so I was just curious for those in our audience, if you'd be able to share if you're able to notice either in your child or in yourself those kind of either triggering events or some way of knowing that you might be having the onset of a worse day. And just raise your hand and we'll have a mic to you.
Well, as I said, I'm quite old right now, but I do remember being in elementary school and having like stabbing pains and bending over, and they would call my mother and she would come get me. And this went on from elementary school right through forever. But anyway, I was told I had the stomach flu. So then they would give me, they didn't have endoscopies in those days for pancreases, but they would do, GI tract x-rays and colonoscopies. and they would give me Valium, and then they'd say I had an ulcer, and they'd give me ice cream and cream, the worst possible thing for pancreatitis. So I have to say, until I was diagnosed at 22, I was in camp, I was in high school, I was in college. I spent a lot of time in college, in the hospital at college, and it just lasted from the time I can practically remember, 5 or 6. It was torture.
Did you ever notice anything that would trigger those events, or was it just pretty random?
No, it would just sort of happen. And I'd go to the nurse at school, and I'd sit there for a while, and they'd call my mother and say, oh, she has stomach flu. Mm-hmm. I remember being in camp one summer, and they told, for 2 weeks I was in the infirmary, they said I had stomach flu. Mm-hmm. And, and then in college, that was the worst. They told me I had an ulcer, and they gave me everything you shouldn't have for pancreatitis. And as I said before, I was finally diagnosed at 22, which is when I sort of knew how to control low fat and all that. But this was a different time, and I'm so glad these young people, even though they've suffered, there's better understanding of it, because it was pretty bad.
Sure. Thank you so much. Other experiences on this? Yes, Jane? You all can raise your hand at any time.
I just want to say I've spent 32 years trying to figure out what triggers my pancreatitis, and I can't figure out anything. It just happens. Mm-hmm. I think I said I try to be very careful with what I eat. I do what I'm supposed to do. It doesn't make any difference. I just get the pancreatitis, and nothing I can do to change it.
Sure. Thank you so much. Just pass that right there. Yes, Addie?
Okay, I know for me specifically, nothing really triggered it. I could be fine 1 minute and the next minute in excruciating pain. But once an attack would be over, and even after the surgery, we could step back and kind of look, the more dehydrated I was, the worse the attack would be. So we finally noticed a pattern after several years that the attacks became worse in the summer whenever I was outside playing, going, not drinking water. So for me, I would say one of the things that not necessarily triggered it, but probably was a factor, was the dehydration.
Thank you so much. I know earlier in the day we heard a little bit about food. Does anyone have experience where specific foods might trigger, or even just eating? Obviously eating is a common thing, but any patterns noticed there? Hillary, did you want to? So, right here.
It can happen at any time, but there are certainly triggers that when I look back, I know what triggered it. The first time I had acute pancreatitis, I had been eating granola and nuts, like a trail mix, and had no idea I wasn't supposed to eat nuts. Stress is also, when I am under severe stress, I try whatever I can do to calm myself down, because I know that that can lead to an attack as well.
Absolutely. Thank you, Hillary. We also heard, so we've heard about stress, dehydration. We heard a little bit about food. Anybody else have a experience where hormone changes triggered pancreatitis attacks? Oh, we have a couple hands. We'll come here, and then we'll go to Holly.
Yeah, I can relate to Gracie. Every month that I would get my menstrual cycle, I would end up hospitalized. The attacks would be so bad. And so I'd be in the hospital for about a week every single month. And so they ended up putting me on an IUD to stop the menstrual cycle from happening, just so that they could stop that cycle from recurring every single month.
Sure. Thank you, Adriana. Holly?
I've noticed with being pregnant now for the third time that it didn't happen my first pregnancy, but the second one at 36 weeks, it was like the more the hormone surged, the worse it got. And it could have also been, the smushing all of your organs inside. The pancreas does not like to be crushed. Don't touch it. Don't put pressure on it. But now, this time around, I feel like I'm just waiting for the inevitable. It's going to happen. And I can kind of feel it almost now. And I don't know if it's the stress sometimes, speaking in public makes you nervous, or hearing these things, being emotional and crying, which I can't seem to stop doing right now. Really, it's like it like tenses up almost like a cramp in a muscle. And I know the hormones with being pregnant is something to take into consideration when you think about it, just to kind of try to relax as much as possible, because the stress and the hormones all together, and with your menstrual cycle, it's just, I have noticed it more in women in my family than I have in men, and I'm wondering if that's playing a factor. I don't know. I've heard it's not gender specific, but it just seems to affect, in my family specifically, more women than men, and I'm wondering if it's hormone related.
Interesting. And did you, in your past pregnancies, have kind of increased frequency of that feeling, or even the onset of the symptoms themselves?
I did. The bigger that I seemed to get and the less room the pancreas had, I would notice it more. And then with breastfeeding, that's when I had the worst pancreatitis attack that lasted for the longest. Probably it lasted for 9 months. It never went away. And I want to say it was Jane who had said that you noticed you have a pancreas. It's weird to notice that you have a pancreas and to feel it working. And I do. I notice my pancreas is actively working. That's not something that is normal. You shouldn't notice that. Kind of like your liver, you shouldn't know it's working, or your kidneys. But with your pancreas, I had noticed that as well. And yep, the bigger you get, the more you feel it, and the frequency is more intense.
Absolutely. Thank you. Any other noticeable patterns? Do you want to? Yep.
Okay, I'll talk about the noticeable patterns, and then I'm going to give another few words on behalf of children that I see on a regular basis. We happen to have the privilege of starting a charity for children with pancreatitis, but we see dozens and dozens and dozens and dozens of children that come in with this disease path. So we've done so many studies now on the children and their diseases. The triggers are one into the next. We do have a lot of children that are triggered by fat still, and I know there's a lot of research say no fat or not, but a tremendous amount of children, including my daughter Rebecca, who was the first to speak there, that are triggered by fat. So I get a little nervous when everybody's like, oh, don't worry about the fat. It's not a big deal, because we have so many children that are coming in with that. Again, that doesn't mean that that's always the case, but we do have a lot of the fat triggers. There's a lot of the stress triggers, especially for children who have a lot of stress from school and from academics, or things that are coming. So that runs the gamut. But I also want to just speak to the broader issue of thank you for hosting this meeting, because I think it is paramount in the world of pancreatitis, but especially in the world I see with children. Because again, adults get it, they get affected, and that's just horrific. But to see a young child who has their entire childhood taken away from them because of this disease path is something that's excruciating. And I see that all the time. A huge portion of our children don't even attend school. They have all had to drop out and have some form of homeschool because they cannot keep up with the rigorous education, and the education portion itself does not understand why they're missing so many days, because it's not a known disease path. The second I wanted to be able to bring up is the lack of education that we have about this disease path means that children, again, as Dr. Bellin attested to, go to the hospital, and we get children all the time. One example, 2 weeks ago, we had a patient of ours that went to the ER, had already been diagnosed with pancreatitis, went to a major hospital in Dallas, Texas, and the ER doctor looked at her and said, that's impossible. That was a fluke on the test, pulled the child's feeding tube out and told her it was all in her head. So the psychological ramifications that are coming with a developing child's mind to not be able to understand that this doctor is telling them something that's wrong, we are seeing magnified to the point where these children not only don't get a proper childhood, but they don't understand the emotional and mental and cognitive ramifications of what they're going through, and we don't address that at all. And so it's not just, as you had mentioned, the pain factors and so forth, but it's also the emotional side. We have children, many that have attempted suicide, some that have committed suicide, and a lot of that is actually based upon the pain factor. And because you have doctors that say, I'm not going to give you opioids. Rebecca, as a 10-year-old child, I'll never forget a doctor calling me outside the room. Her amylase and lipase had not risen. It was lagging because she had had so many attacks by that point. He pulled me outside the room and said, your child is just drug seeking, 10 years old. My child had not had a drug in her system in 9 months, and yet she was a 10-year-old that's drug seeking. And you're being told that as a parent, and the child's being told that what they're saying is not right and that their pain is wrong. We had a nurse that would say, what's your pain factor? And we have this happen all the time. And, Rebecca would say 7, 8. And then all of a sudden, the nurse would say, you don't look like it's 7, 8, so I'm going to put a 2 down. So after a few days, Rebecca just stopped saying her pain factor. Why did she stop saying her pain factor? Because she wasn't being listened to. And the doctors were fearful a lot of giving the opioids because of the new opioid crisis that we're having. We are from Texas, which there is no cannabis or any of those options. So the child is not getting pain medicine to manage the pain. They have no other alternatives, and they do want to die. So to have something that's an alternative outside of removing multiple organs, again, we're thankful for the T-PAID. It saved my child's life. But the ramifications we're having and a lot of other children we're seeing is about 50-50. 50 have terrible repercussions after the T-PAID from scar tissue and other post-splenectomies and so forth. The others do really well. But if you're in that 50% as a child that's growing, it's very difficult. The fact that we could actually start conversations for the first time about addressing the pancreas and healing from itself without something radical will be not just life-changing from a physical perspective, but will be life-changing from an emotional, mental, and cognitive standpoint too. And I'm very thankful to be actually opening up conversations about that. Thank you.
Yeah, no, thank you for those comments. A lot to unpack there, and actually would like to explore some of those exact issues with the audience and hope to draw out some more of the experiences of those we have in the room today. So, kind of getting maybe first to the point of, stealing, the childhood. These people living with pancreatitis in these early years, childhood, teenage years, and the impact that these symptoms, these health effects, even the healthcare treatment and the burden related to that we've heard about, the long hospital stays. What are the impacts have that been on the pediatric patient, so the child or the teenager's activities in daily life? What are the things that are most important to our pediatric patients that have been limited or maybe impossible because of having to live with pancreatitis? So I'd like to hear any examples, stories that you might have that might exemplify those losses. Yes?
Again, my name is Michelle. I did not have a diagnosis. I mentioned earlier my first round was at 7 years old. We had no idea what it was. I had no idea. I was just told it was in my head. I was just sick all the time. Didn't get to do anything enjoyable. Didn't go to summer camps, couldn't go anything like that. It actually even changed my track in life. I always wanted to be in public safety. Actually wanted to go into the armed forces and follow my family's footsteps. Couldn't even do that, couldn't do public safety. Went a safe route, started as a teacher, it just wasn't it. So then got into business and that just wasn't it. Finally, when I was 30, I got my diagnosis, had a laparotomy, was told things were gonna be fixed. If anything, it did help my psychological factor because then I did go into firefighting. I did firefighter 1 and 2. I'm now a basic EMT as well. Was on a truck, found out I wasn't fixed and was having increased problems. So I've had to come off of a truck, and now I actually work as a fire marshal. So I'm still on fire prevention, still doing something, and it has fulfilled a part of me to be able to do something that I wanted to do all those years ago. I joke and I say I'm going through my second childhood because for so long I was so worried about what was going to happen. You couldn't eat. Didn't know. Couldn't eat too much, but I'd eat too little. Couldn't hydrate, would be dehydrated. Did not know that balance till I finally stopped and I listened to my body. And now I know what's right for me, and to have people here and the FDA and other doctors to listen to the patients say what's right for them. There's no cookie cutter for any patient. And right, you're going to have a whole gamut of things. But to have a quality of life, it is priceless. I mean, it is just, there's nothing that can replace being able to smile, being able to be happy, being able to do something that fulfills something in you, which I'm 39 years old and I'm just getting.
Wonderful. If you don't mind me just asking a question, you gave as an example not being able to go to summer camp, and so that's something that clearly was a decision that had to be made, well in advance. You didn't sign up. Was there certain fears of certain symptoms onsetting, or was there, you just knew you had a chronic level of symptoms that wouldn't allow that? What kind of?
Pretty much. A lot of it just being lethargic, tired all the time. I always wanted to be active, but then there's a lot of GI issues, and again, did not have a diagnosis with it. This is 30-some years ago, so it was the fear of, and then what would happen if, we have the one extreme to the other with bowel movements and that sort of thing. What am I going to do when we're out on a hike and something like that happens? So even now I have to deal with that. Do I eat before I go to work? Do I try to snack? Do I just wait until the end of the day? What do I need to do? Now as an adult, I have more choices and I have more freedom, but the children don't have that, especially when they don't know what's going on.
Sure. Thank you so much for sharing. Other experiences? Yes, right here.
Just to echo something that I've heard a couple times, I was 18 when I had my first attack, so I was already in college. But being told it's all in your head, I'm sure most of us have heard that many times before. And I think part of the issue with that is, you have these symptoms that are going on. You see doctors, that doctor probably sends you to another doctor, to another specialist or something like that. After you get a nice 6-month workup, they say, okay, well, now we're going to send you to a mental health professional because we can't find anything wrong physically. And it's just, I think that the effect that those kind of comments have can be pretty tough on somebody, especially children. So I just think, again, that's probably one of the reasons that mental health professionals could be involved from the very beginning of the process and not kind of as an afterthought thrown in at the end.
Yeah, and kind of that mental, psychological burden, have you noticed that in your own life, having downstream effects in daily life?
I think initially so, but then I was able to get connected with some resources 2.5, 3 years ago, and it's been life-changing. So,
thank you so much, John. Other experiences in life, impacts that on activities. Rebecca?
Because I'm a high schooler, you want to be normal in high school and be able to go to school. But when I'm at home, I can only attend school for an average of 3 days a week, sometimes 3.5 if I'm lucky. And it's very difficult to be separated by that barrier from everybody else while you're attending school, to only be able to go certain times when you're feeling well, or to have to leave school so often from pain, and to have people who are telling you, who think you're just seeking attention. So you try to hide it all so that other people don't see that. And for example, last August, I went to a summer camp and I had very bad stomach pain that just kept piling up, but I wanted to be normal for once, so I didn't tell anybody. And I stopped eating so that it wouldn't cause pain. And eventually, halfway through the camp, I ended up passing out one night in front of everybody and had to be taken by an ambulance to the emergency department. So you have to try to maintain this balance to be seen as normal by everybody else when clearly everything is wrong and it's not.
Sure. Thank you so much, Rebecca. Okay. So I'm going to maybe transition the conversation a little bit to talking about treatment approaches, something that's come up a number of times on our panel and throughout the discussion. Maybe to start that off, we'll go to our second to last polling question, and encourage everybody, all our patients and caregivers, to respond to this, both here in the room and online. So here, earlier in the day, we asked you about the different treatment approaches that you've used. Here we want to get a sense of, in general, how much have those medications and other treatment approaches helped to improve your quality of life. And options are A, you've had no benefit at all, B, they've helped somewhat, C, they've helped a lot, D, they've had a very significant benefit, or E, you're not sure the benefit that they've provided. Please select the one that most closely reflects your experience with medications and treatments and how much they've helped improve your quality of life. I'll give you just another moment to get in your response here. As it stands, I would say vast majority of people, around just under 2/3, have said that those treatments and medications that they do have available have helped somewhat. We have about a quarter of people saying that they've helped a lot, just under 10% saying no benefit at all, and a small proportion of people saying they've had a very significant benefit. No one reported that they were unsure. And so, of course, this all depends on what treatments that you've had. And we want to explore those treatments that you've experienced and how well they've worked, which of these categories essentially it's fallen into. So maybe a place to start in that category is we heard that there, Erica shared a little bit about this, there could be some unique considerations for disease management in childhood, and maybe perhaps more so in early childhood, but maybe also into teenage, high school years. So I was wondering if anyone had any examples where maybe some of the treatment approaches we talked about in the adult section have had either you've had difficulty in implementing them during childhood years, maybe they weren't available to you for some reason because of being in childhood years, or maybe there's just some issues with even being able to comply given the nature of childhood years. So any experiences, unique experiences with difficulty in managing the condition because of childhood. Any thoughts on that? Yes.
We found in the pediatric world it's really difficult getting doctors to take pediatric patients with this disease path. So that's one of our biggest problems that we're having. There will be probably 10-to-1 adult doctors that will take on pancreatitis patients versus the one child. And a lot of adult doctors don't want to delve into the field of pediatrics. I'm sorry, I'm blocking half your view. Some of the doctors don't want to dive into the world of pediatrics, which is understandable. But we're having a hard time with children coming from all different portions of the U.S., actually even pinpointing a hospital that will take children with this disease path. And not just outside of the MPO, stick an IV in, give them some opioids and let them rest. What happens beyond that next step? You know, we have one patient in particular that spent 6 years, went to 4 major university hospitals, hospital to hospital to hospital, large hospitals, and would never take her as a child patient outside of sitting in the hospital with IVs. So I think an awareness, of course, of this disease path that trickles down is helpful, but also educating and training pediatric doctors themselves or adult doctors to take on the pediatrics is something that needs to be addressed for the welfare of these children.
Yeah, so to help me maybe understand the impact of that lack of access to kind of care, is there, are people not getting on the right diets? Are they not getting on the right medicines?
Oh, they're having severe damage by the time we actually see a lot of our children in San Antonio or at other institutions where they will take them. They're already at a severe chronic pancreatitis state because they've spent years traveling from place to place to place and have had no help. What would have happened, and there's no way to have a crystal ball to look, but if they had had intervention that was appropriate from either medication, and again, that's assuming that we get medication that can help that. I'm not just discussing opioids. From medication intervention or even an ERCP. We have some of our patients that needed one ERCP, a very simple fix, not that you would say ERCP if you don't need it, but a simple fix, and they're in remission for 9-10 years. But because they didn't get that and their inflammation continued year after year after year, by the time that we get them at kind of a last stop resort, these children already have so much damage it's irreversible. And when you have a young child with growing organs and irreversible damage that's affecting their health, it's affecting their physicality, it's affecting their growth rates, it's affecting their liver, it's really a severe process.
Sure. Thank you very much. Other unique challenges or barriers to treating pediatric pancreatitis? Yes.
So one success story we had from Dr. Lowe was my son's first 3 attacks were time regulated for some reason, every 100 days, give or take. And Dr. Lowe suggested the combination of Centrum Silver and methionine. I know I said that wrong, you have to excuse me. But I have absolutely no doubt at his earlier ages that completely expanded the time between attacks as well as the duration of. And as it started to wear down, we figured out that because he was a growing boy, we needed to increase the dosage. And I still believe that that contributes in some factor to those well periods, although they are a little bit shorter in between now.
Sure. Thank you. Any other kind of broadening it, unique treatment experiences? Maybe not. This isn't a a manifestation of being a kid making it harder to comply with learning a diet, staying on a diet. Same with changing medical or medicine regimens. But anything in terms of treatments that you might have tried in childhood that really haven't been talked about yet, and again, treatments being thought of broadly, not necessarily just medicines, medical procedures, but anything, maybe management within the school system, or, special categories of care like physical therapy that might be leveraged in childhood. Yes.
My name is Jenny, and I am Addie and Gracie's mom. And I would just say that some of the things that we've dealt with in that, a few things actually. One, when you put your teenage daughter on birth control, that's a conversation that you have to have. She wears a patch, and so people see it, and so that it just brings it up. But it's also, we can use it however we want to, and we choose to just use it to educate. So that is one factor. The other thing that I would say too, we worked with Addie. So Addie was diagnosed at 4, and I was a teacher. So she actually would just, rather than her missing school, she came to my classroom. So we spent a lot of time with her in my classroom trying to get her to feel better. And if we could push her through, then we would send her back to class. So those are my friends who were her teachers, but that's just one thing that I would say definitely is, as much as you can communicate with the people that you have in your school, if you've got children with pancreatitis, is as much communication as you can give up front. That is best. Addie now has had the TPIT, and she does take the enzymes, but the bathroom is a situation for her. They're loving, I'm talking menstrual cycle and diarrhea. So they've never been more proud for me to be their mom. But she is, so we have to have that conversation with teachers that the bathroom is a situation. She is in high school. She does not want to be embarrassed. And so we have education plans for both girls in place, 504s. And we have not done an IEP just yet for the girls, but it is something that I would definitely recommend you do if you have a child that's facing this because of the absences and things like that. And so that plan can follow them even into college so that they would be taken care of, so that they don't have to be dismissed because they have an illness. So I would say that that's definitely something for children that you need to advocate for. And then again, just as much communication as you can give to the teachers, as much education as you can give to them as well. Things like this, if you could get the teachers to just have a short little, I know there are so many things out there, but any little session that you could give them will really help them to to help your children, and you just have to advocate for them, you know. But the way that you go about it too, we tried to not pull Addie from as many things as possible. We tried to keep her active in dance, and because that was what she loved, and that was what kept her going. And so there were times that we would, she was trying out for a competitive team. She ended up missing the tryout. She was hospitalized, but as soon as she was out of the hospital, that team allowed her a special tryout. And so we didn't have to really pull her from all the things. There were times that she would go from the hospital to the stage, or from the stage to the hospital, one way or the other. But we tried to just sort of keep her involved and active as much as possible, as well as, you know, you're sick, but we have choices that we have to make. And so those were just ways that we tried to deal with it as well.
Sure. Thank you. Yeah, in the back.
Patrick Salami from the foundation. We've had a number of schools approach us with questions about how they support children with chronic pancreatitis in school. So over the last 9 months, we've started developing a toolkit based on conversations with some children. Once we have something we can work with, we're going to put it out for consultation with parents and students, and then hopefully have it on our website to support schools and to support parents and students as well. But it's going to help them when they're going into school, so the teachers are prepared to understand the needs and how to support the child with chronic pancreatitis. Thank you.
Yeah, thank you. Yes.
There is one topic that, whether it's adults or pediatrics, that we haven't really addressed, is that of course, when I was young, no doctor wanted to discuss pain medication. And then as an adult, as the years went by, your internist, your GI, they didn't really want to discuss that because they were afraid of ramifications. They didn't want to discuss pain management other than maybe Percocet. And then a number of years ago, maybe 8 years ago, it became law that if you want pain management, you go to a pain management doctor. And I think this applies whether you're an adult or a kid, because there are times when you need adequate pain management, and your doctor and your surgeon are just not going to deal with it. And so my advice would be, if you had a kid or you were an adult like me, because what happened is when I had my surgery, I had been doing pain management in San Francisco. The fellow that treated me wouldn't give me pain management. And I was in agony. I was in the hospital for a month because I got MRSA and pneumonia. I had to call San Francisco to the pain management doctor and have him call the hospital so I could get pain management. So I think that this is, for people of all ages, a major topic, and that if you're suffering, you go to a pain management doctor. That's it.
Thank you. So one topic that, while we're talking about treatments, I saw that a quarter of people said that their treatments have helped a lot. And just from hearing the different testimonies of people from throughout today, probably a lot of that response is driven by TP-IAT procedure. And so what we also heard, though, is that there are trade-offs that come after having that procedure, kind of lasting effects, and they were varied in what we've heard. So I wanted to see, those that have had that procedure, how has that helped a lot, in fact, and then also, what have been those lasting, perhaps, trade-offs that have had the greatest impact on you specifically. So any experiences with that procedure? And it's okay if it's, we've heard it come up a number of times. We want to both understand kind of common experiences as well as unique experiences, but your personal take on those. So Yes, Addie.
I would definitely say, like, I feel very lucky that can say I'm like one of the success stories in which I know pancreatitis is never a good thing, and it's a horrible thing to have to say, that you feel good, that you feel that it's better about having something so terrible. But the lack of pancreatitis, I would say, is worth it, even though there is other things you're facing. And for me, it's not as severe as some people, which I know and I thank God for. I have friends that I've met through the surgery that have different issues, and I was telling Rebecca last night, we're all the same, but we're all so different. So for me, some of the things that have been more impactful are mainly the uncontrollable bowel movements. That's big for me, and one of the things was specifically right after the surgery, the getting tired so easily. And I lost so much weight after the surgery and things like that. Just things that as a kid, I don't want to slow down. I don't want to, and that's, it's kind of an argument between me and my parents. I was like, well, I'm not doing it if I'm not going to get to do dance competitions, things like that. So more I don't know the word for it, but like psychological, I guess, impact of it, I would say is one of the greater things of I don't want to get slowed down, but my body won't allow that.
Sure. And was that slowing down something that was kind of temporary, even if it lasted a little while, or have you bounced back from that, or is it still kind of, a problem?
I would say it is temporary, the severe part, but there is still times that I, might have to leave an event or can't go as long as other people or can't do this because of the surgery, even though it's not as bad as it was, maybe 3 months, 2 months, after the surgery, it's still there.
Mm-hmm. Sure. Thank you so much. Other experiences in the room? Yeah, go ahead. Yeah.
Okay, so as I said before, my daughter had TPIAT about 15 months ago. It's been a complete life changer. It's completely saved her life. She has no pain. She can eat anything she wants without any digestive issues or pain. Yes, there are some lingering complications. She is fully diabetic. She takes pancreatic enzymes with every morsel of food. She does get more fatigue, and there is the who knows if it'll ever go away PTSD aspect and the mental aspects and the challenges of completely changing your life from a mental, emotional perspective. But she's getting on with her life. She calls having TPIAT her midlife crisis, and everything is changing, and she's on her way. So complete success story.
Sure. Thank you. Yep.
Sorry, I feel like I'm talking too much. I'll just give a brief something. I see both sides because we've sent a lot of children through for the TPATE, and of course I have Rebecca. Rebecca has not been the fabulous, great, wonderful, story, but she's alive. So we're thankful. So I think a lot of that comes with twofold. A lot of patients go into TPATE thinking this is going to be an end-all, be-all, fix it. And so when their mindset is set on that and it's not, they become even more depressed and more upset afterward because they feel like they've gone through this huge, enormous surgery. I see a lot of nods of understanding this huge, enormous surgery, and yet they still have a lot of complications. And so I do think what Hillary was saying, it's a big mindset. Know that you're going to have complications, and if you have that set. But a lot of parents have the thought process and patience that I'm going to do the surgery and everything's going to be great. And for 80 to 90%, their life is irreversibly changed one way or another. And that's a big step that they're embarking on. I do also think with the TPATE, one of the negative sides of it, there's so many positive sides, and we've addressed that, is the scar tissues and other things that are happening on growing children's bodies. And again, that's something that seems to be a little more unique with children than it is in the adult population that we found, because the growing children's bodies with 40 some odd staples in their body as it's growing and is ripping and tearing, and we're having lots of repercussions and lots of children hospitalized afterward for that. And there's not a really good answer on what to do, because prime example for Rebecca's situation, there's no surgeon in Texas as of right now that will take her to go and clean up the scar tissue. So she just lives in this constant state of pain, and it's, a lot of nods again. This is not a problem that's uncommon, we're finding, especially in children. So, when you're the same size and you're not growing and you're not having those issues as an adult, it's a very different story. But you've got a 5-year-old, 6-year-old body, 12-year-old body, and they're still continually growing. And we are having a lack of post-TPATE care. And that's our biggest issue we're having right now for the pediatric population. Again, adults is different, but we're having a lack of post-TPATE care. It's like we've done the TPATE, now the endocrinology side of it is down to a science. Dr. Bellin is one of the most brilliant doctors I have ever been around, hands down. The endocrinology we have down to a science. The other repercussions, because we're kind of entering into new territory, we're really struggling with what to do for any complications, and we don't even know where to send these children, or my daughter, prime example, to be able to get the help that they need after that. So a big word of caution for both sides.
Sure. Thank you. Yep. Comment here with John.
I know we've discussed all the pros for the total pancreatectomy, so I'll skip over that. But I had my surgery in 2013 and did really, really well for a period of time afterwards. But then I started to get some gastroparesis type symptoms, was getting constant nausea and vomiting, lots of pain again, and it was like, what's going on? I'll preface this by saying I absolutely love my doctors. I wouldn't trade them for anything in the world, and they take great care of me. But throughout this, I've been able to travel to different medical conferences around the country. And one of these conferences I ended up at, I was talking to a physician afterwards, and he was like hearing similar stories from other patients. He actually is not a total pancreatectomy surgeon, but so I was able to travel to their facility to get kind of checked out again, and that's when they found that I had issues with adhesions and scar tissue and issues with the anastomosis sites for when they put my intestines back together. So because of that, that situation, I was able to find a surgeon back in my hometown. And just the first week of December, I had another revision surgery. And I'm still on my enteral feeds, but everything's looking a lot better than it was beforehand. So there is a lot of adhesion type issues that do come up. And I agree completely that there's not a whole lot of what do we do afterwards kind of thing. So.
Great, thank you. So I want to move to a question, and I'm going to broaden this to both the pediatric and adult perspectives. We're going to start it off with our final polling question. So here, we're going to kind of spend the last time we have together talking about your preferences, your priorities for a future treatment. And so we're going to start that with this polling question, which is asking you, which ability or symptom would you rank as most important for a possible drug treatment today? And you can select your top 3. The options here are decreased pain, B, improved digestion, C, improved ability to participate in sports or activities, D, improve the ability to work and engage in social activities, E, fatigue, F, anxiety, depression, or G, some other ability or symptom that would be most important for a possible drug treatment to treat. So I'll give you a moment to think about this. Pick up to 3 responses. Just give you another moment. Pick your top 3 symptoms or abilities that you would rank as most important for a possible drug treatment today. As it stands, it looks like the top, and again, these are percentages of responses, not of total people answering. The top ability or symptom that you would rank as most important to treat is the pain. After that, you'd be looking next, most important would be an improved ability to work and engage in social activities, followed by, I guess, number 3 would be improved digestion, although fatigue, anxiety, depression, and other were all rated by a number of you as being a top 3 priority. It looks like maybe 1 or 2 people might have selected improved ability to participate in sports and other physical activities. So with this in mind, and don't feel limited to the responses that we gave you as options, we want to think about, again, as I mentioned at the outset of the meeting, we would all want a cure. But short of that, we want a pipeline of treatments that might be able to help you improve, upon what you have today, which we've talked a lot about. And there weren't a lot of responses. Actually, it was maybe 1 or 0 responses that said that the current treatments gave you the greatest level of benefit of the options that we provided. So clearly there's room for improvement, and we want to understand what that improvement could look like. So the question is, short of a cure, what specifically would you look for from that next future treatment, something that would provide a meaningful benefit in your life? And Hillary, do you want to start us off?
I spent about 10 years of my journey as a single mom. And the use of opioids before my liver started to atrophy was not an option most of the time because I had to pick my kids up from school. I had to be with them. And so I think there has to be some focus on being an adult and responsible for other lives around you. And my kids hated seeing me on pain medicine because I wasn't me. So the ability to still be me and still manage to do what I needed to do while not being knocked out on pain medication. And I also want to say that most of the people who are experiencing any form of pancreatitis, their pain threshold, I guarantee you, is among the highest of anybody that you'll ever know. So when they tell you that they're a 6, 7, or 8, in the people who've never experienced that kind of pain, it's off the charts because you learn to tolerate a certain amount of pain. You learn to live with it every single day, and that becomes your normal. So when you're saying you're in pain, it's crazy amounts of pain. And I think it's important for practitioners, medical professionals, doctors, to understand that when they're dealing with it.
So Hillary, I have a follow-up question for you. Beautiful articulation of, avoiding the side effects of opioids and other painkillers, kind of you not being you. You're talking about then, second, pain tolerance and the high pain tolerance of patients with pancreatitis. Would there be a benefit to even knocking that down just 1 or 2 notches on that pain scale from that 7 or 6 you described to a 6 or a 5? Or
any relief that you can still be you is worth it, any. And that's why I think a lot of us use alternative things. It's why heat's so important. Having relationships, having a partner and having them see you in constant pain, there's a debilitating psychological aspect to that for them. It's exhausting for the people around you to watch you go through it. Yeah. And I think sometimes even harder for those people because they love you and they feel so helpless, constantly being told there's nothing else that can be done. And those psychological ramifications are coming out. I'm starting to see my kids who are in their 20s, early 20s, going into therapy after all those years of being a kid, watching me go through what I went through and all of the baggage that they now carry because of that as well. And the fear of, could this happen to me? Is what you have genetic, and am I going to get this? And that fear alone is intense.
Sure.
So.
Thank you. Yep, well, why don't we'll go to Jane and then Eric.
I think it's really important right now with all of the emphasis on opioids and getting rid of opioid drugs, there is an increase in research on alternative things for pain medication. And I think it's really important that our patients get included in some of these studies, or at least find out. I don't know if the FDA can help us to find out when there are new pain medications coming in. I don't know how we can access this information, but there's a lot going on. I know you have the workshop going, which will be very helpful, but how do we as patients, how do we make sure that when there are new pain medications come in, not all of our physicians are going to hear about it. How do we find out about it, and how do we get those available to us?
Sure. Well, let me put a question back to you. We'll make sure that the foundation takes that as a action item. But
we've been working on it.
Yeah. But so for those pancreatitis patients that make it into those trials, say we're successful at getting them enrolled in those studies for new pain treatments, what would be a improvement? How would you define improvement for them? What amount of benefit would you need for them to see to say that they're really getting a real treatment effect when they're participating in those studies?
So that's a very important question, obviously something that has to be determined. But I feel that quality of life, an improvement in quality of life, even it's 3 points would be better.
And what do you mean by quality of life? Because I think people use that term a little differently sometimes.
Well, if you look at quality of life questions, whether it's Promise 29 or if it's Pangole or what it is, they ask you more than just your pain level. They ask you, are you able to sleep at night? Are you able to socialize? Are you, how, in the last 7 days, has your pain affected you in this way, that way, or another way? And so it not only is doing just your level of pain, but how it's affecting you in your life.
Sure.
And I think if we can find anything that will affect our quality of life and make our quality of life better, it would be a huge thing for us. I mean, I don't think any of us think we're going to get a cure. We just want a better quality of life.
Sure. Thank you. And maybe one way, what people said is quality of life includes the ability to work and engage in social activities. That was a number 2 to pain. Yes. And Hillary noted, and not compromise other organs. But Eric, I'd love to hear your thoughts on this question.
So I'm going to present a slightly different perspective on that. The dealing with pain is critical, especially in the short term, and nobody should have to deal with this much pain on a regular basis. But pain is a signal that's telling your body something for a very good reason. And if you have this disease, you just have to trust me, there's an underlying inflammation that affects you across the board. And the fatigue, again, like to be at 10% or 20% of your usual energy level, I mean, that is almost, for me, as noteworthy as the pain, right? I can fight through pain, but you can't fight through having zero energy. And there are a whole bunch of other complications that we haven't discussed and won't have time to discuss that affect a ton of other organs. And if you get a bunch of patients like us together, we start talking about the effects on your hands and your arms and your eyes and other things. And what keeps me going, like I can deal with the pain, but I need to know that within 5 to 10 years, folks like us are going to have some treatment for the underlying inflammation. And Erica said that too, and we're all trying to do that, but I want to stress, like, if we're going to prioritize things, pain modulation is incredibly important, but we have to go beyond that because there is a ticking time bomb that we're all facing, and we have to address it before it goes off.
And what's the ultimate outcome that if something were to treat your underlying inflammation, what would you hope that would do for you and the pancreatitis and the disease?
So I'm going to give you a slightly longer answer. For me, one of the most important things is a lot of patients, you go in and they don't give you a plan. Mm-hmm. There is no plan. And psychologically knowing, okay, we're going to try this, then we're going to try this, then we're going to try this, then we're going to try this, or here's how it's going to progress and here's what we're going to do with it. That, from a psychological perspective, is critical. And I think it's not happening except maybe among the very, very top pancreatic specialists. And they just don't have the tool set. Yeah. So yes, there are daily quality of life impacts that need to be addressed, like fatigue and pain, but just to have a roadmap so that folks know that this is a degenerative disease that's eventually going to get worse until you have to go maybe through radical surgery, but there is a plan, to me, is in some ways the most critical part.
Yeah, and I just to ask, because you mentioned it, that it is a degenerative disease, would it be meaningful if that treatment helps slow that degeneration?
Absolutely. For me, it doesn't. necessarily have to get better, but to know that the underlying inflammation is not just going to snowball is really the important thing.
Sure. Thank you. All right. Oh, yep. Sorry. Here, we'll come over here, then you'll be the closing comment.
I don't know if it would be an approachable thing, and I might be ignorant, but hydration, if there could be a focus on hydration, because I think I've heard a theme of other people, and then also as being a first responder, a lot of medical traumas, a lot of issues that I go on are contributed to dehydration. So that could be a focus as well. I mean, I know there's a lot of things being thrown at the wall for pain, but that might be able to treat and get to the core of the matter instead of just treating one of the symptoms that everybody else is kind of focusing on. But if there was a way to get hydration easier, how many ER trips would be saved? I know myself, some of my ER trips, I would go, they wouldn't even give me fluids because I was a drug seeker. Sometimes it would take 2 to 3 hours to get the fluids. So if there could be a pill, if there could be some kind of way to be able to get the hydration easier, FDA approved, I think that that could go a long way to improving all of these things.
Sure. Thank you. And last comment?
I just want to add on, because I think it would be remiss to leave this meeting with having everyone think that while this is a terrible disease and with terrible symptoms, and it is degenerative, and so many people, children and adults, suffer, there is hope. There is hope. There's a lot of work going on. Numerous people have mentioned in their answers that they have genetic variants or mutations, hereditary pancreatitis, commonly PRSS1 or SPINK, CFTR, which is also the mutation that is associated with cystic fibrosis, is now appearing in probably more than 50% of patients with chronic pancreatitis. Much more study needs to happen with that, but finally, through the advances in genomic sequencing and other technologies like artificial intelligence and machine learning, we now have tools to be able to target what is actually going on that causes all these symptoms, and can start to have researchers and developers working on treatments that, if they don't cure, they slow or prevent progression of the disease. And we're not there yet, and it's still going to take years. But I don't want to leave here having this kind of common, none of us believe we'll ever have a cure. I don't believe that. I believe in less than 10 years we will have a cure, or at least effective treatments that make you forget about pancreatitis. And for me, that's good enough.
Sure. Thank you. As you could probably tell with the podium kind of collapsing on me a little bit, we're getting towards the end of the meeting here. But no, I just want to, before we close out the meeting and I introduce our next speaker, I want to say personally, for me, as your moderator, thank you. I know it's difficult. The questions that I asked were difficult, and pulling back the curtain on your own experiences and shedding light into what are very difficult things. I mean, obviously the pain alone being tremendous, but incredible impacts on your lives, and a whole snowball effect. I think I heard it referred to multiple times. It takes a lot to be able to share that, and I just feel so honored to have been able to work with you all today. Come into your community as an outsider and have you share all of that. I think it's going to make a huge impact on that pipeline of treatments to make sure that they're really being developed for things that are important to patients and caregivers. And so I just want to have you all give yourselves a round of applause, because it's truly incredible what you've done today.